Pidcock. I work at the Kennedy Krieger Institute, which is a pediatric institute for treatment of children with brain and spine problems, and I'm also on faculty at Johns Hopkins. I've been asked to make some comments about the presentation of transverse myelitis in children, and what I'd like to do is focus on some of the things that may make pediatric transverse myelitis different. I'll be making some brief comments about the incidence and demographics in kids, clinical manifestations, etiology, diagnosis, treatment, and prognosis. This is a lot of the information that we've already heard this morning, so there will be some repetition, but what I'll try to do is point out what's known so far in terms of what might be different in presentations for children versus adults. So to begin with, I took a look at, well, are there case series about children? And it turns out there's only about 4 published. And as you can see, they span the time from 1953 to the present time. And I put in some information about the Johns Hopkins Transverse Myelopathy Center information as well. The other difference about these 4 studies is the Johns Hopkins information is the only one which has collected data from different centers, and the other 3 represent information collection from one center each. The first and largest study was done by Dr. Payne in Boston, and as you can see, it covered about a 20-year period from 1929 to 1952. Dr. Dunn in Australia has the second largest number of pediatric cases, and he reports about 21 cases covering the time period from 1966 to 83. In the 1990s, Dr. Knebusch from Germany reported a small case series of only 8 subjects, and currently in the Johns Hopkins group we have about 16 subjects that we have enough data on to talk about. Again, what we're looking at is a small subset of a rare problem, so it's very important that we think about ways to pool our information so that we can learn some more about the various manifestations and outcomes for this problem. We're guessing that the number of cases of transverse myelitis in individuals under 18 years of age accounts for about 15% of the total number. Excuse me. Okay, so what I'm planning on doing is comparing some of the findings in these 4 case series. And one thing that I was struck by as I went through the information was there's a lot of disagreement between the 4 studies. We're not coming up with very clear-cut patterns. However, there are similarities. When you look at the age of onset, what's on this graph is the percentage of cases under 6 years of age. And you can see that it reaches between 30 and 50% for 3 of the 4 studies. In Dr. Payne's study, which dates back to the 30s and 40s, the most frequent age of diagnosis turned out to be 5 years of age. So there were more children in his study with TM that were 5 than any other age. Dr. Dunn, by contrast, reports a clustering of individuals in the later childhood years between 10 and 18, but he was the only one to do so. This study here, about 38% of the children were under 6 years of age, and in our current ongoing series, about half of the children were under 6 years of age. Here's the age distribution of the children with transverse myelopathy in the Johns Hopkins series. And as you can see, pretty much every age was represented. there was no one age which had more than 2 cases represented, and there's really no distribution or bump or peak in the early teenage years that was reported in some of the other studies. When you take a look at the difference between males and females, I think Doug said earlier that we were surprised to find in our pooled sample that the females were more prevalent than the males. So the bar graphs represent percent females, and as you can see, more than 50% of the cases were females. The only study where the percent males were more than females was the small study from Germany by Dr. Knebusch. The other 3 studies, it ranged from about 32 to about 45%. We've gone through this slide 3 or 4 times today, where we look at what are some of the key clinical findings in transverse myelopathy. So let's take a look at what the presentation in children may look like. Again, if we go back to our 4-case series, you can see there's a trend noticed in the 2 earlier studies, which is different than the findings in the 2 more recent studies. In the pain study, the most frequent presenting symptom was pain in close to 50%. The most frequent was pain in the pain and done studies, but it was found in right around 50%. In the small study by Knebusch, pain was only reported in 10%, and in the Johns Hopkins group, pain was much more appreciated in about 70% at the time of onset. The finding of incontinence was an infrequently reported finding in the 2 earlier studies. However, as you see with the 2 later studies, over 50% of the families of children involved who had transverse myelitis presented with incontinence at the onset. And in the Johns Hopkins study, weakness was almost present in all of the subjects. So some unique things that may pertain to symptomatology in children. When they do have pain, it's found in the back extremities or the abdomen. Neck stiffness was reported in about 1/3 of the cases. Fever was found in about half of the cases. Position and vibratory sensation, if the exam was reliable, was generally spared, which goes along with the findings in adults. And what I'd like to point out at this time, sometimes it's very hard in a child to get a reliable examination. Their neurological findings you're going to have to be based on your physical exam findings. Sometimes they're less cooperative than you'd like them to be. Of course, pain, anxiety, being around strangers is a very troublesome thing for a child, and it may be hard to tease out exactly what some of their subjective findings are. The other aspect about childhood, which is different from adults, is they're still developing. So especially in the young child who may not have achieved continence, it'll be difficult to classify whether or not that's incontinence or not. So you have to go back to the family's history and find out if these are changes in their neurological symptoms or not. Weakness we've talked about as one of the cardinal findings in transverse myelopathy, and essentially this doesn't differ between children and adults. You can see a rapidly progressive paraparesis, usually starting with the legs, but may sequentially involve legs, then the arms. Flaccidity is often the initial finding, with gradual appearance of pyramidal or extra pyramidal signs by the end of the 2nd week of the illness. Sensory levels, this is usually documented in almost all cases. It's usually between in the thoracic level between T5 and T10. 20% of the cases of children are felt to have cervical involvement and 10% lumbar involvement in terms of the sensory level. This is another topic that we've talked about quite a bit this morning, which is coming up with an etiological cause for transverse myelopathy, and this is what our 4 studies reported. And in the cases of these 4 studies, they broke it down. I broke it down into illness, was there trauma-related, idiopathic or no known preceding cause, or was an immunization reported as a possible etiological factor. And you'll see quite a different pattern between the four studies. Of interest is that the pain study showed a high relationship of immunization, and this was one of the earlier studies. This was the earliest case series that was reported. The study by Dunn doesn't mention any of these 3 other etiological factors. They stated that if they thought trauma was a case, they did not include that in their case report. So we don't know the incidence of preceding trauma in the Dunn series, and also in the series by Dunn, if they suspected a infectious disease related cause, they were admitted to an infectious disease hospital. So this series here also missed those cases. However, even stating that when they looked at their case series, they found 8 cases where there was a preceding gastrointestinal or upper respiratory tract infection. This was the only study that reported a seasonal clustering of the cases of pediatric transverse myelopathy, and what they found was a increased incidence of presentation during the winter months in the southern hemisphere, which would be our summer months. The study from Germany, they reported a small incidence of preceding illness. There was a 30% incidence of trauma, but don't forget this is a very small study, and they reported no preceding event in most of their cases, and in this study there was no mention of whether there was preceding immunization or not. In the study that from the Johns Hopkins transverse myelopathy group, about half of the children had a history of an immunization within 4 months of presentation. Many of them had a preceding illness, and I think this does speak to the point that children do get upper respiratory tract infections quite frequently, up to 3 to 4 per year during the first 5 to 6 years of life, and they're also getting immunizations. And as pediatricians develop more and effective immunizations, the number of exposures goes up too. So it's hard to tease out whether there's a causal relationship between respiratory illness and immunization and the onset of transverse myelitis. However, this is what the information showed that we have so far. So some specific items about etiological factors in children. If you take all this together, about 2/3 have a history of a recurrent or a concurrent acute infection. And I think Doug mentioned this before. Infectious disease is not associated with the course of the disease. It seems not to predict whether it's going to be an adverse outcome or a favorable outcome. You've seen this list before as well, possible causative infectious agents, and I won't belabor the point that pretty much the list can go on and on in terms of infectious agents that have been related to TM, and this is also true for the pediatric age group. Dr. Knabush, in his article, they did do viral titers to look for a causative agent, and only 1 out of 8 of his cases showed a rising titer to echo virus 25. That was the only evidence in his case series that there was a connection between a specific known viral agent and TM, and he assumed that the others had a a post or vaccinal related myelitis picture. If you look at the types of immunizations that have been associated with TM, in terms of our group at Johns Hopkins, the report was any one of these these were the immunizations that were associated with TM. The one that was most frequently associated was the DPT immunization, which accounted for 3 of the cases. The Hib or influenza type B was 2, as well as the HBV vaccination. The time preceding immunization, from the experience that we've had here in the cases that we've looked at so far, 2 of the cases there was less than the child had received an immunization less than 7 days before onset. In 1 case, 7 to 14 days. 2 cases, 15 to 30 days, and then 3 cases, more than 30 days, but less than 4 months after the immunization. And as you can see, these are still very small numbers, and it again points out the importance of trying to put together a national consortium of centers that look at the presentation and the course and the treatment of transverse myelitis so that we can better understand the disease process. And I think this is even more important for the pediatric group, since we're dealing with a small percentage of a rare problem. So just a sort of a summary slide about the etiology of TM. This is the same as in adults. Possible causes would be a suspected cellular or autoimmune process, which may be para or post-infection. And as was mentioned, this should only be diagnosed if other treatable causes can be excluded. It can be caused from a myelitis from direct infection of the spinal cord. And then we need to worry about myelitis in the context of a systemic autoimmune disease, especially the collagen diseases. In one of the articles that we looked at, mentioned that there was a Medline search done for causes of childhood TM, which were non-para-infectious. So these are the known cases which are related to direct infection. So in a 7-year period from 1990 to 1996, a Medline search came up with 18 infectious cases, 9 viral, 5 parasitic, and 4 bacterial, and only 2 cases of autoimmune disease in childhood, 1 from systemic lupus and 1 which was associated with an antiphospholipid antibody. So in terms of the incidence and the known causes for TM in childhood, it boils down to a very small number of cases. Now, this is true of 1998 when this article was published. I think we're going to be learning more and more information as we go forward in terms of identifiable causes of TM, especially causes in pediatrics. Again, this is just a slide that goes over some of the things that we think about in terms of the differential diagnosis. Acute infectious polyneuritis Guillain-Barré syndrome, something that needs to be ruled out when you're looking at the diagnosis in pediatrics. And of course, we need to rule out spinal cord occupying lesions, which was mentioned in detail in the previous lectures. In terms of evaluation, these are 3 of the commonly used interventions, techniques that are used in evaluation. And and we just talked about the MRI as being a very important component in the evaluation. Spinal fluid, as was also mentioned earlier, doesn't seem to be that helpful in terms of making a specific diagnosis, and electrodiagnostic studies does seem to have a place in the diagnosis of TM. Only 2 of the 4 studies that I looked at had enough data for me to present regarding CSF findings. These are the 2 earlier studies by Payne and Dunn. And as you can see, a normal CSF was found in about half of the cases of pediatric TM reported by Dr. Payne. In the case series by Dr. Dunn, he reports normal in only about 18% of the cases, but only about half had increased protein or increase in the number of cells. So a lot of this information is hard to understand and interpret. I think we need to collect more information. Electrophysiological studies. Now, this is something we haven't talked about too much so far. These studies are helpful in differentiating central versus peripheral causes of damage to the central nervous system. An altered visual evoked potential or a brainstem auditory evoked potential is not compatible with the diagnosis of transverse myelitis. So this is something that you might want to do soon after the functional MRI studies to rule out one of the space-occupying or vascular problems that you can see with TM. Prolonged somatosensory evoked potential latencies or missing SEPs in conjunction with a normal sensory nerve action potential does indicate a central nervous system lesion like transverse myelitis or multiple sclerosis. And then the last electrophysiologic study that might be useful are transcranial magnetic stimulation. However, in pediatrics, this is of limited value in children under 12 due to incomplete maturation of the pyramidal tracts. And another very practical point here is that children don't tolerate these studies very well, especially those who are under 7. They don't like the idea of electrical stimulation or myography, so it does have a limited role in the pediatric age group. And as we talked about earlier, the MRI is useful for ruling out a number of significant problems that you'd want to address right away if they were present. I'm going to skip over this slide because I know we've heard quite a bit about this morning, and I think it's sufficient to say that in the pediatric age group, it's just as important to obtain MRI studies as it would be in the adult population. Okay, so let's talk a little bit about course. Again, there's no major differences that I found in pediatrics versus adults. Without therapy, improvement starts 2 to 12 weeks after the peak of symptoms. However, this is an interesting question. How long does it take to regain function after diagnosis? In other words, what percentage of recovery after the initial onset of symptoms and the nadir of the symptoms can you expect to find after 6 months, after 12 months, up to 24 months? And I think this opens up the whole question of, well, what do we know about the rehabilitation of individuals with transverse myelitis? And I would say that we know very little about that. And I think this is definitely an area which requires further studies. Most of the information that's available, rightly so, focuses on the initial phase and the presentation and the diagnosis and the treatment. But after that, then what? What are the techniques that lead to better outcome? How long should those techniques be used? What information is there out there that suggests that you should keep getting therapy? When do you stop giving intense therapy? Those are those are questions that we don't really have good answers for yet, and I know it's probably a source of frustration for many of you, because when you speak to the therapists in your area, there's not a clear understanding about what's been tried and what works best. So although this isn't a talk about the rehabilitation of transverse myelopathy, I think that's an important topic, and hopefully we'll be learning more and more about that as the years go by. Treatment, this goes back to, well, do we have any information on the initial treatment? And I think we're going to be hearing a lot more about this as the symposium goes forward. And I think the jury's still out about the efficacy of intravenous steroid pulse therapy. Now it has shown some benefit in a pilot study, but to my knowledge, there hasn't been a controlled study performed as of 1998. So again, there's a big need here to try to study these questions in a careful, well-designed method to see, whether some of the observations that we've had and that we've made really are statistically true or not. The pilot study that I mentioned was published in 1997 by Dr. Sebree. And they looked at 5 children with severe transverse myelitis. It was an open study, and they compared their outcomes to 10 historic controls. The outcomes that they look at were the median time to walking, the proportion with a full recovery, and the presence of adverse effects. The findings of the study, let me pull up my notes here. Okay. The findings of the study suggested that those individuals who received the steroid pulse therapy did better than those that did not. Walking time in the treated group, median walking time in the treated group was 23 days versus 97 days. For the control group, 80% of the treated group was reported to have a full recovery versus 10% of the non-treated group. And a full motor recovery was reported in 100% of the treated group and 20% of the control group. Again, I caution you, this is a very small study. It's only 5 treated individuals, and it needs to be duplicated or replicated in a larger group. There were no serious effects reported by these authors in this treatment group. Now, if we go back to our case series, Dr. Knabush in 1998 was unable to determine whether IV pulse steroids led to an improved outcome, primarily due to his small sample size. Dr. Dunn in 1986, he comes out and says that there was no evidence that outcome was improved in the steroid group. And the oldest study in 1953, Dr. Payne did treat one patient with IV corticotropin followed by intramuscular steroids, and that one patient recovered with almost normal function. So this is a question that has been looked at and batted around for at least 40 years in the area of treatment of children with transverse myelopathy. In terms of outcomes, this was looked at in an article by Dr. Knabush, and he pulled information and calculated these numbers from different review articles. His definition of a good outcome was the gait was essentially normal with mild urinary symptoms and or minimal sensory and upper motor neuron signs. And by pooling the information from several different articles, he felt that about 44% of the individuals had what he called a good outcome. A fair outcome was mild spasticity but independent ambulation, urgency and or constipation, and some sensory signs. That was in about 1/3 or 33%, and he reports a poor outcome with the inability to walk or a severe gait disturbance absence of sphincter control and significant sensory deficit in about 23%. And these numbers are not too far off from what was reported earlier today by other speakers. And this is just how the breakdown looked for these two groups, pain and done. A normal outcome was reported by both groups as the most common outcome, about 30 to 40%, good outcome between about 20 and 30%, and poor outcomes ranged between about 10 to 20%. Dr. Payne also had one child die in his group. Dr. Dunn did not have any fatalities. In terms of clinical indicators, things that might suggest a poorer outcome, this is the same list as you've seen earlier with adults. Backache as a first symptom is felt to be by some groups as a poor prognostic indicator. A very acute outcome with maximal symptoms within hours of presentation, signs of spinal shock, and sensory disturbances up to the cervical level. These have all been thrown out there as possible poor prognostic indicators. Again, I think we need more information from larger samples to determine whether these indicators really do predict a bad outcome. Thank you for your attention, and I think we're ready for some questions. Okay.
Okay, so now it's your turn. You can ask questions, any questions for the speakers of the morning. The only question the only statement I would make is many people will have individual questions about your own cases and things like that. I would say let's not do that here, but rather...
Hard question to answer. There's a lot of medications that people try, and my own feeling is that they sometimes work and they sometimes don't work. So I think you have to look at the pain in the context of that particular child and the interventions that are being used. And I think children, like all of us, need the support of our families and of the therapist. So rather than say, this works for childhood pain, I think you have to really look at a multidisciplinary approach to it. And it's going to change from child to child. So sorry, I can't give you a specific answer.
Other questions? Radiologic. Oh boy, he's gone, so okay. Well, go ahead. We'll do our best.